There's some really nice questions for one of our latest papers on management of kids with Osgood Schlatter. And you've written me a lot of emails and tweets surrounding it. Some had questions on outcomes and if knee strengthening at all was important. So instead of trying to respond to each of your questions, I've decided to do a short walkthrough of the paper with you. For those of you that like videos or audio instead of reading a paper, and then towards the end try to put it into context and discuss some of the good questions you had. So hope you're keen on listening through and get some answers towards the end. So we're talking about kids with Osgood Schlatter, and that is by far one of the most common knee complaints in kids. Some of the nice work back from 2011 in American Journal of Sports Medicine showed that it might be 10% or maybe up to 20% in some specific sports where the kids will at some point experience Osgood Schlatter. So these kids would usually complain of knee pain just below the kneecap on the lump or the bump they have below their kneecap. They would complain of pain during jumping or running or squatting, sometimes a bit of swelling. Usually it's always activity dependent, so when they rest they rarely would have pain. And today we can see that Osgood Schlatter is managed in many different ways. Some would advise rest, some would use ice, some would say let's immobilize for a short period of time, some would do exercise or injections. But the question is, how do we best help these kids get back into full game and play? The reason why Osgood Schlatter is important, why we shouldn't just use wait and see, or at least not just think that it goes away, just give it time, is that we've done a bit of research in our group, a retrospective study done by Clark Gullhammer, also published in the OJSM, where we looked at kids with Osgood Schlatter that were seen at a sports medicine department or an orthopedic department at the local hospital. And then we followed them up 3 to 4 years later, and we could actually see that roughly 60% of these young kids, who are now 4 years post their diagnosis, actually still had what they considered OSD related pain. And for the majority, this also affected quality of life and course, sport and recreation. And my take on is that we have this small group of kids with Osgood Schlatter, because a lot of them will most likely do quite well. They will suffer for short periods of time, but we do have an uncertain proportion of these kids with Osgood Schlatter where the pain actually really sticks with them for much longer than the expected 6 to 12 month symptom duration. Maybe these are the kids that we should pay particular attention to. And when you listen to what we've done today, it's worth highlighting that the kids we've included also had pain for many months before we included them, so they would also be considered sort of the more severe end of the spectrum. And that's, I think, super important to highlight, that when we're talking about kids with Osgood Schlatter, we do have the young kids who have a bit of pain after practice for a couple of weeks. That's one group. But then we also have the other group who's had Osgood Schlatter related knee pain for 12 or 18 months on and off. And they're two distinct groups. I want to get back to that towards the end of the presentation, because that's one of your questions. Should we manage all these young kids the same? One of the things that our study builds upon is a cross-sectional study that we published not too long ago in JOSPT. And in that we compared pain and sports participation and physical function in kids with patellofemoral pain, kids with Osgood Schlatter, and compared it to young kids without knee pain. What we can see is that it have a massive impact across these different domains that of quality of life, pain, or sports participation. And one of the interesting things is that we also collected knee strength in that cross-sectional paper. And what we could see was that, especially in the knee extension direction, the kids with Osgood Schlatter, both young girls and boys, had roughly 30 to 35% lower knee strength compared to kids without knee pain. That kind of makes you wonder that if you advise rest or just withdrawal from sport for a certain period of time, will we really target and modify these large strength deficits that these young kids have? And when you look at how Osgood Schlatter is managed today, you'll find lots of different ideas on how it should be done. There's a few narrative reviews, there's very little good quality evidence out there, and they advise a range of different things from cryotherapy and rest or protective knee padding or physical therapy, and some would say it's all about stretching. Others of these systematic reviews will more highlight immobilization, anti-inflammatory meds, surgery, but don't mention anything about more the physical exercise component that could be used in this group as well. So my take home here from the current management of Osgood Schlatter is that it's so variable. We have one of our students doing Christian Lyng, who did a research here where he looked into the current management strategies, and it's been conditionally accepted and should be out with in a few weeks. But here we can really see that clinicians across the world, physios, medical doctors, surgeons, rheumatologists, they use a range of different modalities to manage Osgood Schlatter. And maybe it's not surprising that they use so many different management approaches, because if we look into the evidence, we did that together with Ben Dean from Oxford and Stefan Klutek, led by a few students who did an amazing job, that there's not a lot of evidence out there on how to manage it. And it poses this interesting conundrum, because one of the most common complaints in kids, if we say a prevalence of 10%, that's Osgood Schlatter. But if we look into the evidence, we have close to nothing of high quality to actually guide practice. So maybe that is why practice also becomes very variable, because we don't have any sound, strong evidence to rely on. But when we talk about evidence, we talk about 1 in 10, and we talk about knee strengthening and knee extension strength deficits. I just want to highlight that this is about young kids, and they live in this world where they have an eternal struggle of finding balance. One of the young kids we have in an interview, she said, "I hate my knee pain, but I love playing football." And to her, it was a constant struggle about wanting to be part of the social circles with her friends, the football, but also knew that when she went out and played football, it would aggravate her knee pain. And for her, that was an eternal struggle where she found it difficult to kind of push forward and holding back, because she had such a strong urge of also wanting to be part of her social sphere out in her football club. And in this study, we wanted to investigate the effect of an intervention that focused on patient education, that included activity modification and also a knee strengthening program. So first off, after we included them, we had a visit, we call this visit 1 at 0 weeks, where they were advised to withdraw from any type of sport during a 4-week period. And then in the period after that, at 4 weeks, they were followed up again and instructed in how to perform a progressive knee strengthening program, something that was self-administered, something where they were taught how to push forward and progress the exercises pending their pain levels. We followed them for 12 months, with 12 weeks considered our primary endpoint. As the primary outcome, we used a global rating of change on a 7-point Likert scale. So we asked them, how are you doing now compared to before? And it ranged from much better to worse, or to much worse. And if they said, I'm feeling much better or better, we deemed it a success. If they only said, I'm a little better, all the way down to worse than ever, it deemed a no success. And this was our choice, and this is one of the interesting things on how do we actually evaluate the effect of an intervention, irrespective of study design, but what kind of outcome measures do we use in this population? And I think we actually miss good outcomes, which some of you have also commented on. Is the drug really suitable? I think it makes sense. It reflects how you would often ask a kid in practice, how are you doing now? Does it capture a specific domain? No, it must, or it's most likely individual to each participant. So that is something to discuss. In addition, we also collected outcomes related to return to sport. If they played sport, at which level, pain, and also quality of life and the KOOS. The intervention was centered around this leaflet that we developed. We have it both in Danish, and it's also published in English together with the paper, which is open access. The idea was to empower, explain, and make them understand why they had knee pain and what they could do. And when I say what they could do, it was an intervention that was aimed both at the kids, but also the parents. We really wanted them to take ownership and give them the tools to self-manage. So the idea was both to give them knowledge, but also teach them how to apply this knowledge in their everyday lives. Hopefully, the idea was that would increase their confidence and actually the ability to self-manage these knee pain. One of the components of the activity modification was the activity ladder, which is sort of just gradual exposure to more knee loading activities, where we did it in 11 steps. You started at step number 1, and then you progressed pending how your knee pain changed. And we used the 0 to 10 scale, and we used a modified version of a pain rating scale, where we said that from 0 to 2, we're in the okay zone, and if you're from 3 all the way up to 10, you're in the not okay zone, and then you have to step back a bit. But if you can do a certain task, like on the activity ladder within the okay zone, then you can progress the next day. And here in this photo, this is from the leaflet that we also published together with the paper. You can see how we tried to merge or combine exercise levels and activity levels. So the idea was that if you look around in block number 1, around block number 1, you can see that there's a certain threshold on the activity levels that you have to do. So this was actually during block number 1, which was the 4 first weeks of the intervention. And then afterwards, you progressed to block number 2. They came in for a visit where they were instructed on how to do it. And then the idea was that the exercise levels actually determined the activity levels. So for example, here in block number 2, you would start with the wall squat, 1 set, 5 repetitions at a level that didn't aggravate your knee pain. And then slowly you progress down here to exercise at level 4. So when you can do 1 set of 10 repetitions, 20 seconds with a 90-degree knee angle, when you can do that within the okay zone, then you progress up to step number 2. And then your activities, we try to make them correspond to the exercise levels. So you also progressed all the way up here, and that determined where you were on level of activities. And the rationale for us to do this, and of course when you're out in clinical practice trying to get this to work with your patients, this is not a recipe, this is just inspiration. But our rationale for trying to hold them back a bit, depending on where they were in the exercise levels, were that our experience is that a lot of these kids, they really want to go back as fast as possible to their sport. And we kind of wanted to have I don't know if you would call it a safety mechanism, but at least we thought it would be highly relevant that people could do maybe lunges and squat before they would start to go out to run again. Just to do a basic squat or a lunge before you go out and run or jump. And the post hoc reflection, I'll get back to that a bit later, is that so depending on what the pain levels are when you do these activities, we may actually be holding some kids back from sport for a longer period than necessary, because the exercise levels will actually determine when you're ready to go back into warm up and training and when you're ready to do the match and competition again. And the question is if that is optimal, because we can also see and hear from the kids that it actually takes long for them to get up to the third level to do the lunges and normal squats, and then they're held back and can't be part of the exercise, or part of their physical their team sports. That's the word I was looking for. So our post hoc reflection is maybe we should reconsider this. Maybe part of what we always do is to try to find a way to keep them in the warm-up session, or keeping them being part of the club, which we didn't really embed in a strong way in this study. But we can see from the qualitative research with the kids that being part of the environment out in your sport club is super, super important for them, and one of the priorities they have if they were to design an intervention for themselves. So this is not a recipe, and maybe consider if we can do anything that we combine both the exercise, because I think there's a strong rationale for it, looking at the big strength deficits, but also trying to make a meaningful activity that ensure they don't get back too quickly into sport, or at least not go back in full into sport before they can at least do lunges and normal squats with a certain level without that being enough to aggravate their knee pain. So results were that we included these 51 kids between 10 and 14 years of age, and 3 out of every 4 were still sports active, but some of them were forced to stop due to their knee pain. The average duration of their symptom was 21 months. So this is important when we talk about what kind of patients is this applicable to. Well, my take is that this is the very severe end of the spectrum, and here we recruited them through social media and GP practices, and a few from schools. And I think that a lot of them, or also looking at the data, we can see that a lot of them have been at the GP. Some have been at the orthopedic department and been told just to wait it out, see what happens. So when we put up an announcement on Facebook, they of course very interested in participating, because they've been waiting and not really been able to do anything, but just told to wait and see how their knee pain improves. And this is a busy slide, but this is our key findings. Here on the y-axis you can see the percentage success, and then down here on the x-axis we have the different time points where we asked how they're doing, from 4 weeks all the way up to 12 months. What we plotted here is the rate of success, and as I told you, if they said they were much improved or improved, we, the researchers, deemed it a success. And you can see that roughly after 12 weeks, when we had our primary endpoint, around 80% said they were either much improved or improved. So that suggests a good outcome. But if you then look at playing sports, and remember we had these restrictive rules for when they could go back in the sport, that it was actually also determined by the exercise levels, that only 16% were back playing sport after 3 months, and roughly 70% after 12 months. So a lot of them came back to sport, also pain-free, but some didn't return back into sport, and a few of them actually said to us that they lost interest in trying to get back into sport, or they found other interests. And when we asked how many would consider themselves completely free from knee pain, it was roughly 50%. So based on these outcomes, you could say, depending on if you look at the global rating of change, which is our primary outcome, or you look at the rate of return to sport, the picture changes slightly. But what I think is important is that 71% was actually satisfied with the result of the treatment after 12 weeks. So it appears that the kids are actually quite satisfied with the result. Not all, but quite a few of them are. And more importantly, or at least as importantly, 96% would recommend the same treatment to a friend. And a lot of these kids have been waiting for their knee pain to improve. And what you hear from them is that they get frustrated when they're told to wait and see and avoid any activities that aggravate their knee pain. They just wait, and it's so frustrating to kind of just wait and see how things change. And from talking to some of these kids and the parents, they suddenly have something that they can do. They have a plan and a way forward. They have some exercises they have to do. They have a clear plan and a few goals where they can always see, okay, the next goal is to hard bicycling. The next goal is to do slow running without any knee pain. So they have a sort of a path forward. And I think that's really, really important. What I think we can also use this for is to talk about treatment expectations. Sometimes when you would see these kids in the beginning, they would be frustrated because they were told by their GP or a physiotherapist that it's Osgood Schlatter, it will get better and most likely it will disappear within 3 months or 6 months. So some of these kids and also parents especially, it's so important that we also talk about expectations. And even here in the more severe end of the spectrum, it's clear that a lot of them will continue to have some kind of ongoing knee pain that needs management. So it's not all cases with Osgood Schlatter that is self-limiting and short-lived. And did we actually change behavior? Because one of the things we also found in our cross-sectional study where we compared kids with patellofemoral pain to Osgood Schlatter to healthy controls is that these young kids with patellofemoral pain and Osgood Schlatter, they really do a lot of sport. They both do a lot of sport, but they're also highly physically active in everyday life. And of course, when we told them to modify their activities, to withdraw from sports during a 4-week period, did they actually do it? It didn't have a super strong effect. If you look on the left hand side here, you can see the first period where we had the baseline. Basically, that is how much sport do they do without being told to change anything. And then during the activity modification period where they were told to withdraw from sports, they only modify with a few minutes every day. But after 12 weeks, some of them continue to have a lower amount of vigorous physical activity per week, and it appears they reduce it around 5 hours per week after 12 weeks. So sort of a big reduction in the amount of physical activity, but remember these are also highly physically active kids. And then you can start to reflect on, well, is it good or bad to get them to do less physical activity? Because we do know that physical activity is essential, it's healthy, it's supportive of a sound development of their young bodies in several different ways. So we can always reflect on how much should we reduce, or is it more removing certain activities? Is it keeping them as active as they can, but try together with them to pick out the 5 most pain aggravating activities and then try to remove them instead of saying withdraw from sport. And that is some of the post hoc reflections that we have on what's the next step in an intervention. And I think the next steps in an intervention is also to think more about how we can keep them in sport or keep them as part of the team, because that seems to be, of course, extremely important for these young kids. And most of all, if there's one take home from this slide, it's about we should modify, never tell them to stop. That is a dangerous thing to say, that your knees are weak, you can't handle the sport, you should stop playing sports, you're not built for it. All these things, don't say it to these young kids, because some of them really will carry it with them for a long time. And if we look at knee function, because remember, as I said, in our cross-sectional study, we found a large deficit in knee extension strength. I have the slide down here where you can see the 30 to 35% lower knee extension strength. Nobody knows if this is a cause or effect of Osgood Schlatter, so I'm not making any assumptions about that, but just that one of the targets we had in our simple intervention was to improve knee strength. And if we look here over at knee extension, we have the group of kids from baseline all the way up to 12 weeks, because we collected knee strength at 3 time points. We can see that during these 12 weeks, they actually reach this red line, this dotted red line, and the dotted red line is actually the level of healthy controls without any knee pain. So during a period of 12 weeks, we can improve their knee strength to the level of their peers without knee strength. And the same goes for the hip abduction direction. And we actually also managed to improve their jump for distance and also jump for height, which improved 13 and 3 centimeters respectively. So I think the point I'm trying to make here is that the intervention also appears to have positive benefits to knee extension strength and also knee function measured by the jump for distance and height. And this is just something we're trying to workshop at the moment, because we don't want to exclude all activities from these kids. And we want to put into kind of a structured approach where we only want to modify the activities that aggravate their pain, maybe even increase other activities that feel fine. So the idea with this, and this is work in progress, is that maybe we should start to use sort of a structured approach and say, okay, tell us the 3 different activities that aggravate your knee pain more. Okay, sprinting is number 1. When is it during the sprint? Well, it's when I start. It's the propulsion. Okay, how bad is the knee pain? Well, it's bad, but it's mostly towards the end of a game or end of a play. Okay, then we could make a plan in the beginning that we could continue sprinting, because this is good for you, but maybe you cut back on top speed or your propulsion becomes just a slight tad slower. And of course, it's not every 14 or 13-year-old that would be able to comply with this, because they're out there playing. But the idea is, instead of withdrawal from all sports, maybe we should start to dissect the different activities that actually aggravate their knee pain. It could be the sport, it could be other things that they do in their everyday life. So instead of holding them back from sport, trying to just take away a few of the things that might be the aggravating factors of their knee pain. Then you have some really good questions and comments. And one of the things I got on Twitter and also on email was the choice of outcome, the grok, that you as researchers actually defined the success, that if you had chosen how many % were back at sport after 3 months, the story would be completely different. And I think I've shown this today and also been clear that the choice of outcome the success of this is depending on how you look at it. And it's clear that we, as the researchers, defined that there's two top categories of much improved and improved that we deemed a success. That is something that's up for discussion. Then another thing was that one from a soccer club asked, well, should we use this management strategy for kids with a short duration of symptoms? And I wonder if we really need to do a lot for the kids with a short duration of symptoms. Maybe for those that just have a few weeks of niggles in the knee, maybe it's more about the activity modification that will be sufficient as a simple plan for these kids. Maybe I don't think that the knee strengthening exercises per se is necessary, and by all means we also need to test this in a randomized trial before we actually know the added value of the knee strengthening, or if any of this actually matters compared to just waiting it out. Third point, you kept them out of sport for 4 weeks. Do you still think that is a sensible approach? As I've said today, this is not a recipe, this is just inspiration. And my post hoc reflection is that instead of taking them out, maybe we should have looked into alternative ways of keeping them in sport, as we discussed today. But also just have to remember that these young kids, they just love their game, and it's so difficult to say to them, you should only go out and play 50% today. It's sometimes you get the feeling that it's all or nothing, it's full on or full off. And that was our rationale for trying to keep them out of sport for a short period of time before slowly weaning them back into sport. But that is up for discussion as well. This kind of also covers, is knee strengthening important? Well, I do think for those with a long duration of symptoms, if we want to make them ready to go back into full sport and we see these huge strength deficits, I do think that knee strengthening or whatever would actually be an important component for them to be able to go back into sport, because we also know going back into sport with a low knee extension strength actually may be a risk factor for other types of knee complaints as well. So added on, maybe it's protective compared to getting other types of knee pain or getting Osgood Schlatter again. And last point, do we know this is better than stopping all sports for a brief period of time? No, we don't know it. That is one thing that's clear from this. This is just a single cohort prospective study. We don't know the effect of this intervention compared to anything else. And that's important to keep in mind, that this is not high quality evidence from a randomized clinical trial. This is just a single cohort study where we try to include some meaningful components for these young kids with knee pain. And lastly, huge thanks to all my co-authors on the paper, the physiotherapists Lucas and Casper, for helping running this trial and seeing and speaking to so many kids and parents. Thank you. I hope you listened, and feel free to send me an email or comment on this if there's anything you find interesting, anything that conflicts with your ideas, or you have any ideas on how this can be built further.